Hi, everyone, and welcome. Thanks for joining me today. This is Jennifer Gross at PointRight, and we're really excited because this is the last in our session of PDPM Educational Series. This is session 7, PDPM the home stretch, because we got less than a month to go now. So just a couple of reminders before we get started. All the audio lines are muted, so if you have any questions, if time permits, we'll try to answer them. Just use the chat in the webinar toolbar to type in your message. And if you want the handouts, you can download those from the webinar toolbar. You should see a link to click to download a PDF of the slides. And as always, at the end of the session, we will give you a link to our survey that you can fill out to get your continuing education credit. So just again, a reminder that this webinar series is continuously evolving based on the latest information from CMS on PDPM. And you'll see where I talk about things that have literally just been announced and just changed in some of the nuances of PDPM policy. So always double check the policy in the current documentation. So just a little overview, if you need a refresher, we have 6 previous sessions. So we started off with the basics of PDPM. Pam Kaiser gave an overview of PDPM and all the payment moving parts. And you can watch the video recording on the link on the screen. And the next session, session 2, Paula D. Natal talked about the non-therapy ancillary components that are driven by comorbidities and ICD-10 coding and other diagnoses on the MDS. Then in session 3, I talked specifically about how ICD-10 codes drive your PDPM reimbursement, and some discussion of primary diagnosis, as well as how other clinical categories may be impacted by ICD-10 coding. So that was fun. And then session 4, I talked about section GG and the ADL function scores, how they differ from the RUG scores, and how they affect some of the PDPM payment categories. Session 5, Paula and I talked about all the different moving parts in the PDPM system, not just the payment based on that 5-day initial Medicare assessment, but also the variable per diem adjustment, the interrupted stay policy, the interim payment assessment, all of which will impact how much reimbursement you would be getting for a particular resident. And the previous session, session 6, Pam and I talked about how PDPM and the requirements of participation specifically related to compliance can dovetail with each other. We know that phase 3 is still under various forms of delay, but we know that these compliance requirements are in the works. So you do want to make sure that you're ready, and how better to do that than make sure that you're compliant with PDPM. Okay, so today's session, we're going to tie up some loose ends and pull together a few things that we didn't speak about in previous presentations. So your objectives, you'll be able to talk through the requirements for the transition from RUG 4 to PDPM as of October 1st, and specifically what MDSs will be required to get your residents carried over from RUGs to PDPM. I'll talk about the HIPS codes, how they're going to be a lot different from the RUG HIP codes that you're used to coding on your claims. And we'll also talk a little bit about some considerations you would want to take into mind when you're selecting those ARDs under PDPM, and potential consequences for not selecting the appropriate ARD. Those compliance fundamentals are still going to be in effect. That kind of segues. A lot is changing, but of course, fundamentally, Medicare itself is not changing. So there are a few pieces that are carried over into PDPM that I wanted to point out that are remaining. The Medicare Benefit Policy Manual, not a single word in that has changed, and is not going to change anytime in the near future. So let's talk about how PDPM looks so much different. As you know, under the RUG system, every time you do an MDS and you submit a claim for a resident, each individual resident for each payment period is index maximized into only one category. So there can't be multiple categories at play for a resident. They're going to rug at that RVB no matter what else is going on with them clinically. And of course, usually this is driven by the amount of therapy that's being provided. Of course, the nursing rugs have to do with the nursing care delivered, but most of the time the case mix index puts them into a rehab rug. But under PDPM, you know, there are 5 components to PDPM. 4 of those 5 are clinically based, and they're all categorized completely independently of each other. So it's so easy right now to say, oh, you know, Mrs. Smith is an RVB. Well, that could be exactly the same after October 1st, but you won't be able to use that sort of language to describe what level you're getting reimbursed at for Mrs. Smith's care. So you will need to learn a new way to speak about case mix categorization, and that requires a good understanding of what the components are and what is driving them. But fundamentally, the floor that everything is built on is not changing. So the Medicare Part A skilled benefit program for SNF skilled services is going to be exactly the same after October 1st. And the rule book is still going to be the Medicare Benefit Policy Manual. Chapter 8 is where you'll see all the details for skilled SNF services. So remember, all of your residents who are in your facility through 11:59 p.m. on September the 30th on your Medicare coverage are going to continue the same Medicare stay. They're not starting a new stay. They're not moving. They're in their beds. They're going to continue under that same Medicare payment benefit. But even though that is not changing, the details of how the Medicare program is being implemented and put into practice are changing kind of around us. So a couple of things that I wanted to point out that got clarified rather recently by CMS are the administrative level of care criteria for the assumption of care and the HIPS codes. So first, very briefly, before I go into what's changing, I also wanted to remind you, because I did notice some people have been asking questions about this. What about the certification and recert process? Well, you know, actually that is not changing a single bit either. Now, it looks like under the RUG system, it looks like the certs and the recerts align with the MDS, because you see on admission and then 14 days and then every 30 days afterwards. It kind of sort of sounds like the regular scheduled MDS, but really it is not at all connected to the MDS schedule. So therefore, it's not going to change with PDPM. So you're still going to need that initial certification by the physician or the physician extender on admission. And then that stay is going to need to be periodically recertified for as long as that resident remains in your facility under that skilled benefit. So within 14 days after the initial certification, but they can be signed on the same date as the initial certification on admission. And then after every prior recertification, you need a new recertification every 30 days. Foreseeably out to day 100 if you have anybody who happens to exhaust their entire 100 days, which you rarely see anymore. So just remember, the whole purpose for the certification and recertification process has to do with the fundamental qualification for that skilled Medicare benefit. The physician or physician extender is certifying that the resident continues to require a skilled level of SNF care in the facility that is related to that qualifying hospital stay that triggered that skilled benefit. So those recerts are really, really important, and not having those certifications is grounds for a technical denial. So there is that piece. Now there is also the administrative level of care presumption, and practically speaking, depending on your facility, you might not have to deal with thinking about this very much, but just to remind you, under the RUG system, and this is how it's been for years and years, administrative level of care presumption has assumed that when a resident qualifies for a skilled Medicare benefit and they come in your door, as long as they would RUG out anything clinically complex or higher in the RUG hierarchy, that they're eligible for, they're presumed eligible for Medicare skilled through the day, the ARD of the Medicare 5-day assessment. So up to day 8, of course, because that's as far as you can make that 5-day ARD. So it was nice and easy because, of course, there can only be one RUG at any given time for a resident. So if this person is at least a clinically complex, you know that that they at least pass that first bar of assuming an administrative level of care. Now, under PDPM, there are more pieces involved because the resident may qualify for a stay for administrative presumption if they fall into at least one of the following PDPM case mix classifiers. So it doesn't have, they don't have to meet everything. You don't have to check off each of the boxes and stay, well, they're special care low in nursing and their NTA score is not 12 plus, so they don't qualify. That's not the case. But these are the automatic classifiers that CMS has said would the resident would pass the bar for at least being presumed of qualifying for a stay through the ARD of the 5-day, which could be up to day 8. So just know that this list of case mix classifiers for each of the PDPM components, if the resident meets at least one of those, they meet that presumption of care. Now let's talk about the actual classification, what will make its way into a HIPS code that will end up being coded on your UB when you submit the claim for this particular payment period. So the Health Insurance Prospective Payment System, the HIPS codes, is still going to be coded on the UB04. It's still going to show up in section Z of your MDS. They're going to fit in the same space because it's 5 characters. But instead of the HIPS code being your RUG being the first 3 characters, and then the second and then the other 2 characters being the assessment indicator code, which could be a 5-day, 14, 30, 60, 90, or a change of therapy, an end of therapy, a start of therapy, blah, blah, blah. The RUG piece was always very easy to remember. In the HIPS code under PDPM, that's going to be a lot more complicated because each of the payment components feeds into one of the first 4 characters, and then the 5th character is the assessment indicator, which has been boiled down to only 3 options. So let's start with number 5, the assessment indicator code, because there's only 3 options. If the MDS is an interim payment assessment, IPA, then the code is 0. If the MDS is the 5-day, which CMS is now calling the initial Medicare assessment, I don't know if IMA is going to be what we're calling it, but that's what we'll see how that evolves in the vocabulary, in the vernacular. But if it is the initial Medicare assessment / 5-day, the code for the assessment indicator will be 1. And if it's an OBRA assessment, so basically anything else is an OBRA assessment, that will be coded a 6. So a discharge, a significant change assessment, anything else that would end up in a code as a 6. Then going back to the first 4 characters, spot 1 is the PTOT component, spot 2 is the speech language pathology, spot 3 is nursing, and spot 4 is the non-therapy ancillary. Now, how do you read a HIPS code? Because it's an interesting language. I was looking at tables that I found in trainings of how HIPS codes line up and with the different payment categories, and I thought I had come on a pattern, and then I realized that I was completely wrong. So here's the best sense that I can make out of it. So the PTOT, the speech, and the non-therapy ancillary case mix groups when you determine that case mix group, it will have a 2-letter code. So the first letter in that code for PTOT is always going to be a T. For speech, it's always going to be an S. And for NTA, it's always going to be an N. Now that makes sense. That's not going to last forever though. Then the second letter goes in descending alphabetical order down the hierarchy. So the very top of the PDPM hierarchy starts with the letter A, and then goes down B, C, D, E, F, G, etc., all the way down to Y or X. It goes pretty down far. So for example, in PTOT at the very top will be TA, and then TB, and then TC. All right, that makes sense so far as well. Now the nursing category, nursing component, follows with the RUG-4 grouper designations. So, you know, ES2, HBC1. So if you look at those RUG-4 grouper designations, you'll see that same type of coding. So it doesn't follow that neat, clean pattern that the other 3 components do. But remember that that PDPM collapses those RUG-4 categories into 25 categories, so there aren't quite as many of them. But the same type of pattern also continues, where you start with the letter that goes onto the HIPS code goes in descending order based on where that nursing category falls in the hierarchy of nursing case mix groups. And then the HIPS code will take 1 digit from each component and plug it into the HIPS code. Now the default HIPS code is 5 Z's, so don't fall asleep at the wheel is the joke, I guess, that is being assigned to this, because usually if you have to bill a default, it's because you put that ARD in the wrong place. So stay alert for that. Now, this is going to make a little bit more sense when we look at these tables. So this is, I've been seeing training materials that lay out these tables very cleanly, so it makes a lot of sense. So I thought I would share this with you as well. Now, this is going to go over onto the next slide, but you see how PTOT, the highest possible categorization, is TA, then we have SA, we have the ES3, and the NTA top score is NA. So each of those would have a HIPS character of A. So if I was A here, that means I have the top of the hierarchical classification for each of the components. And it is possible to have a HIPS code of AAAA1 for my 5-day. And then so on and so forth. Now, of course, there are not the same number of groups for each of the classifications. So PTOT goes down a little bit further. Speech only goes down to SL. NTA only goes down to NF. The nursing category goes all the way down to PA1, which gets a Y. So that's why this goes all the way through the alphabet. Fortunately, it stops at Y so that the default can be Z's across the board. So another thing that kind of makes sense. But this is how this works as far as how a HIPS character is assigned. Now, one thing that you don't see in this table is the case mix index that goes with each of these PDPM categorizations. So always keep an eye on the CMI for each of these categorizations, because sometimes a lower classification like a TC has a higher CMI than a TA, just because of how CMS's research has determined the therapy costs go along with that classification. So don't assume that a lower level in the alphabet means higher reimbursement, because it only does up to a certain extent. So this is here for your reference. I really would recommend, though, sticking to any official CMS rather, CMI tables to see the actual case mix indices that go along with each of the PDPM classifications. I almost said RUG. So let's go through a quick example of what a HIPS code would turn out to be. So let's say, you know, we have a patient, Larry, and he's in the facility, and for his 5-day, he has 500 minutes of therapy, and, you know, mid-range ADLs, he'd be an RVB, right? Very easy. and then it would be RVB and the assessment indicator code for a 5-day. Well, let's see how that works for PDPM. So the reason why he's on therapy is because of an acute neurological event. Maybe he had a stroke. ADL score is 7, so he's a TN. For speech, he's also got some hemiparesis, some aphasia and dysphagia, mechanically altered diet, swallowing problem, a little cognitively impaired. So he's an SL in speech. For nursing, he also has diabetes with insulin and order changes for that insulin. And he has that hemiplegia/hemiparesis, and his nursing ADL score is a 5. So he's an HDE1 in nursing. And then for non-therapy ancillary, he gets 3 NTA points because of the diabetes, plus diabetic retinopathy was also captured in the documentation. So what does that give us? Well, coding the initial Medicare assessment /5-day, that means that his HIPS code would be NLED1. So that's how we end up with this HIPS code that gets coded on the UB. And don't ask me to repeat that from memory because it's not going to happen, but you will learn and you will internalize that. I think the really key points here are just internalizing the positions in the HIPS codes and what components of PDPM they correspond to, and just having a general idea of what the letter designation means as far as the classification. All right. So I already have a question here on that came up that I think I'll address very quickly before we get into the hard switch, because I'm going to be talking about scheduling assessments. So can you combine the 5-day / initial payment assessment with the 14-day OBRA admission assessment? Yes. Not for this initial IPA though, and I'm going to talk about that in a minute. But let's say, it's November, you have somebody new who comes in the facility, you do that initial Medicare assessment, you can combine it with the OBRA admission assessment. Now, whether or not you really want to do that will depend on your processes, and if you anticipate that resident is going to be in the facility beyond day 14, you certainly can combine it, and you would code it on the MDS the same as you do right now with a combined admission and 5-day. And on the claim, it would the assessment indicator code would be for the initial Medicare assessment, that one. So short answer is yes. But we're going to talk about the hard switch, which we have to get through before we get to that point where you're going to talk about combining assessments. So what are we trying to achieve in between the end of September and mid-October? As I see it, you've got 3 main goals here. First of all, you want to make sure that you get reimbursed like you're supposed to for all of the Medicare AIM payment days that you have through September 30th. Don't forget that. You don't want to have any no pay days for September. Secondly, of course, you want to go ahead and establish all of your residents on caseload who are in the facility into October with a PDPM case mix classification for October going forward. And of course, you want to the point of that question I just answered, you want to continue to meet your OBRA assessment requirements, because those are going to stay the same. They're not going away. They're always running in the background. So you want to make sure that you don't miss those admissions, the quarterlies, the significant changes, the annuals, those discharges. They all will still be there, and they're all still required. So how do you continue to meet all of those goals during the hard switch? Because the reason for the hard switch is that you're still going to have to bill for September, right? So every resident you have in your facility covered under Medicare Part A through September 30th of 2019 will need a RUG for billing in September. Now, in addition to that, if this person is newly admitted up to and including September 30th, if you want to bill for those payment days in September, you're going to need to do a 5-day for a RUG. You can't bill without a RUG, or you can't bill anything but default without a RUG. Let me clarify that. So you're going to meet that first need by making sure that everybody has a RUG that with valid payment days through the end of September. Now, the second goal is to do that mandatory transitional IPA for all of those residents who are going to continue on that Medicare stay with an ARD that is anywhere from October 1st through October 7th. It can be no later than 10/7. When you do that IPA, I'll talk about how this IPA is different from IPAs going forward, interim payment assessments going forward. But this mandatory IPA will set the payment, and you can put that ARD anywhere between 10/1 and 10/7. But for this specific assessment, October 1st is going to be considered day one for the variable per diem adjustment for the PTOT and for the non-therapy ancillary. So what that means is for the first 3 days of October, your NTA is going to be ×3, whatever that case mix is, and your PTOT is going to be set, but then it will start to taper come day 21. But this will be day one for that variable per diem adjustment, even if the resident has been in the facility for 3 weeks. Now, as I said earlier, the IPA cannot be combined with any other MDS, whether Medicare PPS or OBRA. It can't be combined with anything. So in order to make sure that you're meeting your OBRA requirements and staying in compliance with that, you can complete that IPA and an admission assessment with the same ARD, but they have to be coded as 2 separate MDSs and have to be submitted separately. Okay. Now let's talk through what the implications of this hard switch will be for your caseload in the facility through September. So RUG 4, the switch is going to be turned off after 11:59 p.m. on September 30th. So that means that you cannot open a RUG 4 MDS after 9:30. You're going to be out of compliance. So you need to plan ahead to make sure that you're not liable for non-compliance. If you realize on September 3rd that, oops, Mary needed a 30-day, you can't go back and open that assessment because you're going to be out of compliance. So make sure you plan ahead to save those headaches. Now, another thing is for your new admissions, because presumably and hopefully your new admissions are going to continue to come in. It would be nice if you could just shut the door and keep everybody stable for the last week or so into the beginning of October, but we know that's not going to happen. Now, I've been thinking about this. Any later than September 26th, when you do that 5-day to capture reimbursement through September 30th, it's not going to be possible for you to have 5 calendar days of therapy. And this is the last MDS where therapy is going to count towards your reimbursement. So you want to make sure that you get it right. Now, what that means is it's not going to be possible to do a Medicare short stay assessment in these cases because this is not the end of the Medicare stay. And that's one of the criteria, one of the 8 criteria that you have to meet to code a short stay assessment. So that's off the table. So if you don't have enough therapy in to get a rehab RUG for that last RUG MDS, make sure you capture as many clinical comorbidities, diagnoses, et cetera, as possible to get a decent nursing RUG, a decent non-therapy ancillary count, because that's going to be the new reality going forward. That first transitional IPA, as I said, that will be day one for the variable payment adjustment, and that will give you the 3x multiplier to the non-therapy ancillary count for October 1st, 2nd, and 3rd. So, get as much as you can off of that. That sounds kind of cynical, but you do want to make sure that you capture fully the residents' comorbidities, because that's that's going to be the new reality. Now, for any residents who are carrying over under a rehab RUG between September and October, the other thing to keep an eye on is your change of therapy checkpoints, because COTs will still be applicable through September 30th, and you don't want to end up realizing you missed a COT on the 29th or the 30th and have to go back and bill default days for that whole 7-day period. So just plan ahead again, and that's what I'm going to be talking about in just a moment. So when you're planning ahead for the switch, I arbitrarily said here 2 weeks out. You might want to be more proactive for this, depending on how heavy duty your Medicare caseload is and if you've got a lot of activity and a lot of churn going on. So of course, you're managing your current Medicare Part A caseload. So compile a list and review the relevant details. So what are they currently rugging at, of course? What's their current Medicare day? When was the last MDS they had? And what was the last MDS? When do you estimate the next assessment is going to be due? And what are the risks? Have they been able to sustain that same level of therapy, or do you think there's going to be a COT? Have they had trouble participating in therapy? Might there be an end of therapy assessment 5 days before the end of the month? Or is there a possibility that this person might actually be discharged to the hospital? Keep those all in mind because then once you get the lay of the land and you have your risky people, take care of the more stable cases, get them scheduled ahead of time first, because you don't want to take your eye off of those uncomplicated cases that you can address relatively easily. But for the risky cases, put them on your watch list and be prepared to set that ARD if there's an unplanned discharge, because the day of the discharge, as the resident's on their way out the door, go ahead, open that IPA assessment or open that assessment, whatever they have due before September 30th, because you'll remain in compliance on that day. If you wait until the next day after the resident is discharged out of the facility, you're no longer going to be in compliance to open that MDS. So I came up with a few examples in this list. So let's say for resident A, he's been in the facility for a while. As of September 30th, his Medicare day is going to be day 57. He's still hanging out there. He's still on therapy. Now, the last MDS we did for him on the 22nd was a change of therapy. So that means that he's going to have another COT check on 9/29. But in my notes, I'm saying, well, you know, he's been pretty stable. He's been participating in therapy. We're doing okay at this level. He's already kind of been titrated down. So we do not anticipate a change of therapy assessment for this guy. So I say, okay, let me just schedule him for 10/1 and we can get that IPA done first, because I can plan ahead for that. And remember, you have to assess section GG for the 3 days ending on that ARD. So September 29th, 30th, 10/1, you're going to be assessing section GG for this person because you're planning ahead for it. Pretty sure that's going to remain stable. Whoops. There we go. Next resident has been in the facility a couple of weeks. On 9/30, they're going to be on day 15. So that means their previous MDS with a 5-day that we did on 9/20. So of course, the 14-day is going to be due before October the 1st. So we're going to need a 14-day MDS to bill for 9/30. So get that taken care of so you don't have to, you know, be liable for that last day in September. But then for the IPA, we're not anticipating any other changes. Maybe we'll go ahead and schedule that a little bit further out for 10/5 and put that person on the list to assess section GG for the 3 days leading up to that. Now for resident C, been in the facility, he'll be on day 21 on the 30th, and we last did his 14-day MDS on the 23rd. So nothing is due before the 1st, and that would be great, except he went out to the hospital on the 29th and he hasn't been back. So this is getting towards the end of the day on the 30th. We're pretty sure he's going to be out 24 hours, so we're going to have to discharge him. So we'll need an OBRA discharge with the PPS discharge to to say he's no longer on an active Medicare stay as of 11:59 p.m. on September the 30th. So everything was going fine until he went out to the hospital. So I'm going to put an NA here for this case because I don't know when he's going to be back. I would not here's the thing: the interrupted stay policy doesn't go into effect until after October 1st. So through September 30th, discharged means discharged, and you're going to have to start a new 5-day. So I put a little asterisk here for the N and an NA, because if the resident returns after October 1st, so he's out over 24 hours, you have to discharge him, he is going to need a new initial Medicare assessment / 5-day because there's no interrupted stay yet. So for resident D, just came in the door. He was admitted on 9/30. So there was no previous MDS. He's going to have a 5-day if you want to bill for 9/30. Now that 5-day ARD has to be on September the 30th. And then, okay, let's wait a little bit. Let's do his IPA. We could go all the way out to the 7th. Just remember, October 7th is going to be on a Monday. So that means that your weekend staff is going to make sure that have to be able to document and make sure that they're assessing for that usual performance in section GG, because that's the 3-day look back period, Saturday, Sunday, and Monday, with Monday being October 7th. So my scenarios were a little silly, but I hope that you could apply something like this to your own residents who are on Medicare caseload, just so that you can understand who to prioritize and who you need to keep an eye on, because you don't want to end up being caught short and end up missing an MDS, or end up with any penalties for late ARDs. So there are a few implications that are unique to this transitional IPA. As I mentioned earlier, the transitional IPA, this is one and done. This is the only time that the interim payment assessment is going to be used for this purpose, at least right now. So the transitional IPA is going to be a different animal from every other IPA in the future after October 7th. So first of all, it's mandatory. After this transitional window is over, the IPA will be optional, but this is going to be mandatory for every Medicare Part A resident in your facility who has billing days that continue from September into October. If you want to continue to get paid for that stay, you're going to need a PDPM designation for that resident. Now, what that means, though, is because this IPA is mandatory, that if you don't set that ARD by October 7th, then the late assessment penalty applies. So you would have to bill default for the number of days out of compliance. So remember that. For this case, it's mandatory assessment, and that means you need the ARD within that window. Now, the case mix classification itself takes effect on the 1st, regardless of when you set the ARD. So I could set that ARD on 10/7, but that classification will take effect on the 1st with the variable per diem adjustment. So if you do your planning, then you should be able to plan ahead and avoid missing any MDSs entirely, heaven forbid, or setting an ARD late outside of that transition window. And that means getting all the pieces in place and getting all the people on the same page so that that 3-day assessment for section GG is done, and making sure that your diagnosis coding and documentation and your comorbidities are all in the documentation by the ARD. And that's why, if you don't already have those comorbidities documented yet, you may want to set that ARD after a few more days and just make sure that you're not missing anything, so that you can get the full reimbursement possible for that particular resident. Now, of course, people can be discharged. What if the resident had to go out to the hospital, for example, on or before October 1st, and they return after October 1st? So that was kind of similar to that previous scenario that I talked about. So if that resident is not on a Medicare paid day as of September 30th, then the transitional IPA does not apply because they're not actively on your Medicare caseload from the 30th to the 1st. So when they do come back, then you will need to do a new initial Medicare assessment / 5-day in order to set their reimbursement going forward. Now, what if the resident was in the building on October 1st, you planned to do that IPA, but they had a fall and went out to the hospital? Don't let them go. Let them go to the hospital if they have to. But again, set that ARD of the interim payment assessment, move it to the day of the discharge, because you're going to need that assessment to bill. And as long as you do it on that day, then you're going to be in compliance. Complete it separately from the OBRA discharge assessment. They're both required for that date, but you have to complete and submit them separately because they can't be combined. And then if and when the resident comes back, you can assess them. If another IPA is appropriate, then go ahead and do it, and you will get the appropriate reimbursement for that resident going forward. I hope you don't have any hard questions for me after that. It's hard to come up with these scenarios and think through everything that might possibly happen, but as you can see, a lot can happen, as you know. So let me talk about a few of the compliance pitfalls in this process having to do with timing. I talked about the interrupted stay policy a little bit, but this does not exist until October 1st. So the interrupted stay policy had an initial description that said that the resident is discharged from either physically from the SNF or from a skilled level of care and remain in the SNF, and they return to the same SNF at a skilled level of care within 3 calendar days. Now that made sense, but CMS really realized that they had to clarify that further because that 3-day window would differ depending on whether it's a physical discharge or if the resident drops from a skilled level of care but remains in the facility. So they clarified in the most recent updates that they just released on a few days ago that the 3-day window begins with the first non-covered Medicare day. So what that means is in the event that the person is physically discharged from the SNF, that is the same as the day of discharge because you don't bill for the day of discharge. Or if the resident is discontinued from skilled coverage but remains in the SNF, that is still a paid day. That last covered day, the next day is the first non-skilled, non-Medicare covered day. So that would be your day 1. So that interrupted stay will shift by 1 day depending on the type of discontinuation of Medicare service. But the late or missed assessment policy will still apply in that case because there's a specific definite time window here. So you do have a potential for default payment or provider liable days if you miss something. So here's a scenario that I had thought up, and I tried to get some clarification from CMS, but they haven't gotten back to me yet. So if the 3-day window is not counted correctly and the resident comes back to your facility for Medicare coverage, but it's day 4. So let's say that the resident was discharged late in the evening on one day, but you didn't consider day 1 until the next day, when in fact it's day 2. And then they come back in reality, it's really day 4 and you thought it was day 3, you're supposed to do a new 5-day. You've missed that interrupted stay window. But if you missed that 5-day, then you're at risk for provider liability or at least default payment days. I haven't gotten that clarification from CMS yet on that scenario. So what that means is make sure that you have, you're very, very clear on when the date of discharge is, when the first non-covered day is, so you know when to count those 3 non-covered days, those 3 discharge days, before you determine if it's an interrupted stay or if a new initial payment assessment, initial Medicare assessment is required. So as a reminder, it'll be a good practice to just wait until that 3-day window has passed before you submit that OBRA discharge or Medicare discharge NPE assessment, because then if the resident does come back within that 3-day interrupted stay window, you can code A310G1 as an interrupted stay on the discharge MDS and shoot that off to CMS. So patience can pay off. Don't be too hasty in submitting that MDS. Now, for late assessment penalties, there is good news, of course, because there are going to be a lot fewer scheduled MDSs, which means that there's a lot fewer areas that you're at risk for scheduling errors and non-compliance with COT windows and end of therapy and your scheduled MDSs. There was a lot of risk for default days. But it is, as I've described, still possible to actually have ARDs that are out of compliance. First, with that first transitional IPA, you can't have an ARD any later than 10/7 for that first week. Or the initial Medicare assessment going forward, that ARD window is still going to be days 1 through day 8. So anything after that is going to be out of compliance. So how that penalty is assessed is still the same. You're going to default bill that Z, the 5 Z's on your bill for the number of days that your ARD is out of compliance. So if your ARD is 2 days late, you're going to have to bill 2 default days. Now, CMS also clarified that the variable per diem adjustment will apply to those default days because you're billing those default days at the beginning of the payment period. That 3x NTA, for example, would be applied to that default rate. So that's another reason why you want to make sure that you minimize your risk of default payment. Now, for concurrent and group therapy, the policy was clarified and refined under PDPM. The combination of concurrent therapy and group therapy cannot be any more than 25% per patient, per discipline, per stay. Now this does not impact directly PDPM reimbursement, but as you know, you're going to be collecting the total therapy minutes and total therapy days broken down by individual, concurrent, and group on the PPS discharge assessment at the end of the Medicare stay. Now CMS has tweaked the policy. They've changed the definition of group therapy to from 2 to 6 residents per therapist performing the same or similar activities versus 4 residents per therapist currently. So all of this will have downstream implications. But one thing that I want you to be aware of that CMS put in their most recent updates to their materials is that there will be a warning in your MDS validation report when you submit to CMS if that group concurrent group therapy limit is exceeded for that resident. So whoever is submitting for your facility, keep an eye out for that warning edit and make sure that your therapy department and your leadership knows about this, because there's no penalty for non-compliance, but CMS has basically said that there will be eventually. So keep an eye out for that warning. Okay, so documentation and managing your PDPM reimbursement. And I've got one eye on the clock here, so we got about 10 minutes left. So of course, your documentation is going to drive all of the different pieces and all the different moving parts that feed into your PDPM categorization on that initial Medicare assessment, that 5-day. So you do want to make sure that the documentation ducks are all in a row so you can appropriately capture what's going on with that individual patient or resident. So make sure that you are not running into potential documentation issues that may put you at compliance risk or under reimbursement at least. So if that primary diagnosis is not supported in the documentation, whether it's an orthopedic diagnosis, but there's no therapy being provided, that's going to be a big compliance red flag. A major surgery, but there's no wound from it, That's interesting. Or a CVA, but we're not seeing anything that would be related to that CVA to put the individual in an acute neurological category, then that would be a compliance risk. Comorbidities without an underlying diagnosis related to the comorbidities. You can't have a diabetic foot ulcer without a diagnosis of diabetes, or a HEMI without a CVA. A treatment being provided without a reason for it. You got to have something to suction to give the suctioning, or insulin injections without primarily a diagnosis of diabetes. There are other reasons for it, but usually it's diabetes. And inconsistencies in section GG. Facilities still struggle with section GG, but remember, we are looking for usual performance for that resident for the entire 3-day look back period, not just what was in the therapy room, not just what was with the CNAs, not just what was with the family when they were being good, the usual performance over 3 days. So you want to make sure that there is no glaring inconsistencies in capturing that usual performance. So as you know, there are usually certain pieces of documentation that are driven by certain departments. So for example, diagnoses, it absolutely has to be documented by your medical staff. So your medical director heads up that staff, the physicians, nurse practitioners, physician's assistants. Nursing does the communication with that staff if there are any changes that require a new diagnosis. So you do want to make sure that your active diagnoses are in the documentation, and that any old inactive diagnoses, that 6-month-old pneumonia, are being resolved. For pressure ulcers and what treatments are being provided, that's usually owned by the nursing department in-house or a contracted wound specialist, but you do want to make sure that everybody's on the same level as far as their competencies in assessment and staging and documenting so that it matches the MDS. Cognitive assessment, mood assessment, often that's divided between the nursing and the social service department. Activities often contributes in certain areas. So making sure that your residents who are interviewable are being interviewed consistently between those assessments, as we know CMS is watching that. And for ADLs, I already talked about the usual performance, but that's really a team effort between therapy and nursing and the CNAs within the nursing department. Now, not to belabor the details, but you may want to think about this in terms of clinical categories. So if you have a new patient or resident in your facility who falls into a surgical category, whether it's a major joint replacement or other orthopedic surgery or non-orthopedic surgery, what would you expect to see in the documentation that not only drives the PDPM categorization, but also shows the skilled daily care that you're giving that resident, because you have to meet that level of compliance as well. So you'd expect to see a surgical wound, assessment for pain, if they're on any medications like an anticoagulant, lab values, you're checking their lung sounds, you're making sure they're getting up and mobile, they're having therapy. All of that stuff you would provide to a post-surgical patient. Acute neuro, same deal. What's going on that's related to that neurologic event? What the dysphagia, the aphasia, any cognitive changes, a HEMI, and their mobility, their ADL changes, maybe any mood changes that may be related to that stroke as well. Non-surgical orthopedic, again, therapy, mobility, ADLs, pain, if it's related to a fracture, would be tied in with that non-surgical ortho category. Now, there's a lot of pieces in the medical management and other non-neurologic categories. If there is anything medically complex going on with a resident, if they're on a vent, if they're getting chemo or radiation, what's the reason for it? Is there a cancer diagnosis? Special treatments and procedures, that you're tracking the skilled care provided for IV hydration and monitoring fluid status, TPN or tube feeding, maintaining that feeding, the residents having a transfusion, the monitoring on that. medications, if there's anything being titrated or adjusted, particularly for a psychotropic medication regimen review, make sure that's well documented, and any other lab values or x-rays. So if you think about it in terms of those clinical categories, that might help you to make sure that you have the documentation to support that PDPM classification that you're putting this resident in on the initial payment assessment. And you can also structure your Medicare meetings in a similar fashion to make sure you're eliciting that information. So for new admissions, making sure that that primary sniff diagnosis is the right one, and if there are any surgical procedures from that immediate hospital stay, that it's documented so you're getting the right clinical category off the bat. First 3 days, of course, making sure in that Medicare meeting that the Section GG assessment is being kept up so that you have that full 3 days as much as possible to assess and determine usual performance. Now, remember, you have through day 8 to set the ARD of the 5-day. And I would challenge you to be patient and make sure that you set that ARD once you're sure that you have all the information you need to fully code that assessment. After the 5-day, you're keeping up that care plan, you're working on the discharge plan ideally, you are collaborating in your interdisciplinary team on the assessment and making tweaks or changes to therapy. Maybe you're bringing in restorative, you're looking for any changes in condition, because if an interim payment assessment needs to be completed, you want to make sure that it's going to be an appropriate one. So that's the ongoing communication, management, and documentation that will not only make sure that you are you're maintaining that PDPM reimbursement, but you're demonstrating that skilled daily level of care. So if there are any issues with your documentation, the symptoms will show up on your MDS, which is what's going to impact your reimbursement. So if you find MDS accuracy issues, that I would recommend that you focus a QAPI program on it, because you're going to need to address this not just for your PDPM reimbursement, but any other spillover effect to all your MDSs. So look for issues with MDS coding and documentation. If you don't have an MDS auditing system like PointRight or any of our peers in the field, you should have one, because it's very important to help you identify those potential documentation and compliance issues so that you can resolve them. If you find there are actually inaccuracies in the documentation or in the MDS, then find out why so that you can address it. If there's no documentation of a diagnosis that should be there, then you may need to bring in your medical director in that performance improvement plan, because they're ones that are leading the department of the people who diagnose in your facility. If there's a lot of staff turnover, of course, the MDS coding definitions, as you know from painful experience, are always being updated. So making sure that everybody's up to speed on what is required in the documentation is really, really important. And just simple data entry errors that should be caught by your MDS auditing system before you go ahead and submit that MDS to CMS and code that HIPS code on the claim. So from the compliance standpoint, I'd really like to tap in our VP of Product Management, Janine Savage, who's going to talk a little bit more about this compliance piece while I rest my voice. Janine?
Okay, I know we don't have much time, so I'll just give you a couple of observations from the compliance perspective that I have, which is, as a former corporate compliance officer and a long-term and post-acute care provider, I do maintain my CHC, or Certified in Healthcare Compliance credential, and I try to stay very connected to the LTPAC compliance community. And understandably, there's a lot of discussion going on about how compliance and enforcement will change under PDPM. And CMS has been very clear, actually, about the compliance risk areas for providers under PDPM. Very early in the game, they started talking about that. It's sort of a gift, actually. And in the May 2019 CMS provider training, specifically, John Kane stated, that given the more holistic style of care emphasized under PDPM, program integrity and data monitoring efforts will also be more comprehensive and broad. For program integrity, we expect provider risk will be more easily mitigated to the extent that reviews focus on more clearly defined aspects of payment, such as documentation supporting patient diagnoses and assessment coding. So really, we couldn't get more clear about the areas that the government enforcers, as I like to call them, will be looking at. So in order to best position your organization for a compliance-related audit or investigation, unfortunately, those happen, it's very important that you follow compliance best practices, both in your processes and in the tools that you use in your auditing and monitoring programs. And I know there are some PDPM tools out there that will allow you to get the highest payment really without any regard to supporting documentation. For example, a diagnosis optimizer that allows you to pick from a list in a hierarchical order any ICD-10 code, whether or not that code has actually been assigned to that patient through proper diagnosis coding procedures, which of course would include a comprehensive review of the medical record to ensure physician or physician extender documentation. This concerns me and many other compliance professionals because we already know what the outcomes have been and the lessons that have been learned from other types of healthcare providers who have used similar approaches to these. So from a compliance perspective, you should use tools that help you get the highest payment that your medical record documentation actually supports, and only those tools. I'm also aware that some LTPAC, EHR, and billing software vendors are offering MDS audit features and things like MDS analytics within their applications. And from a compliance perspective, you'll be best positioned if you use one of the respected and proven third-party applications that is separate from your EHR in order to audit your documentation and MDS coding related to reimbursement under PDPM. This is kind of an example of that proverbial fox guarding the hen house concept. And kind of my final thought, as I would also say, beware of anything that's free. In my experience, you usually do get what you pay for. And so as a foundation of a very strong and robust, comprehensive, data-driven PDPM compliance program, you need to use best practices and the best tools so that you'll be better positioned to actually keep the reimbursement dollars that you're going to be working so hard, as Jen has illustrated here. You're going to be working very hard to achieve that reimbursement. So you want to be sure that if you're audited or investigated, you'll be able to keep that reimbursement.
All right.
Jen, back to you.
Very important thoughts, Janine. Thanks for giving us your 2 cents on that. Compliance is really going to be very important, and you may find the need or the opportunity for CDI in your facility. Clinical documentation improvement is something that post-acute care is not very familiar with yet. Although in the acute care space, there are CDI specialists embedded in every hospital because they see the value of this. So basically, this is an improvement system in place continuously that identifies any process issues that would affect accuracy and completeness of documentation and addresses them going forward. Now, your MDS coordinators and your medical records coordinators are experts at CDI without even knowing it. MDS coding issues that are due to a documentation issue, your MDS coordinators are going to know about it. And so it's really key to listen to them if they bring things like this up, because that enables you as department heads, I'm speaking globally to department heads who may be on this call, to coordinate with the MDS department and other department heads and the medical staff to address those interdisciplinary processes, and making sure that the ongoing improvement and education on MDS coding requirements are in place so that you are successful, not just with PDPM, but overall in having a solid documentation program. So we are wrapping things up. I'm going to stick around for overtime. There are some questions here, so if you would like to stick around to hear them, I'll take about another 5 minutes or so to answer those. But I want to say thank you, particularly for those of you who attended all 7 of our webinars. We're almost there, so hang in there because you're going to make it. Everybody's going to live through the transition, and we're going to continue providing the great care for our residents as we have been. The usual references are here. I do want to point out the CMS PDPM website had just had a major update right before Labor Day weekend, including some updates to the FAQs and fact sheets that I referenced in the presentation. So if you have older fact sheets, make sure you download the new ones. And the Medicare Benefit Policy Manual is not changed one bit, but if you don't have a copy of it, please go ahead and download it. Any questions, please feel free to reach out. So here's the link to the SurveyMonkey. So you can go ahead and fill out the online survey. Again, apologize, we ran over a little bit on time, but there's just so much to talk about. So please fill out that survey. We're going to keep it up for a week. And if you have multiple people attending with you, please have everybody fill out the survey separately so they can each individually make their way onto our final attendance list. That's how you'll get CEU credit. If you're a nurse, to get your 1 contact hour certificate for nurses, you'll be able to download that certificate after completing the survey. For you nursing home administrators, hang in there. After the week is up and I get the final attendance list, I'll compile it and upload it to the National Association of Boards registry, and NAB maintains your CEUs now, so you'll be able to track your attendance in that registry. So thank you. I'm going to leave that link up on the screen while I go through these answers. So if you want to stick around, I'm just going to get started. So there is a question from a medical records coordinator who struggles with getting clarification of diagnoses, particularly in new admissions, and particularly ending up with return to provider codes. And she'd like some guidance on this. That is really tricky and tough because it does require collaboration and coordination with other providers, often physicians. So I would see if you're a member of AHIMA, the American Health Information Management Association. I think they have some best practice guides for skilled nursing facilities that might be helpful to you. But I would also really recommend getting your medical director on board with you. So if there is a problem, they can communicate doctor to doctor and say, you know, this is what our SNFs need in order to make sure that our new Medicare admissions are getting the appropriate documentation, because you have to code just like the hospital coders have to code. So I hope that helps. I don't have a magic wand, unfortunately. But so there's a question about those residents who come in towards the end of September, but they haven't been in the facility for 5 days. Can you do a start of therapy to get a RUG level? If you don't have 5 days of therapy, you're not going to be able to get a rehab RUG, because the Medicare short stay assessment is not going to be an option if those residents are not finishing their Medicare stay before September 30th, because that's one of the criteria for a short stay assessment. So really your best option is to set that 5-day ARD and just capture as much clinical information as you can on that assessment to get a nursing RUG, because unfortunately time is going to run out on getting those therapy days. How do you code that if the patient's not been in the facility for 5 days? You will get that information from the hospital, hopefully, and your initial assessment of the resident within the first few days. Remember, you do need to get that comprehensive admission assessment done. You need to have the interim care plan in place within the first 48 hours. So just elicit as much information as you can to feed in and establish a RUG on that resident, because they are being admitted to your facility therapy for a reason. And hopefully there will be at least something that will get you at least a clinically complex rug or something. But just remember, it's only going to be for a few days anyway, but you're going to have to capture those comorbidities after October 1st anyway to get your PDPM classification. So try not to have your therapy glasses on, because therapy is not the only reason to admit somebody to a SNF, and that's the whole reason for PDPM in the first place. Let's see. So anyone that's currently on Medicare A or will be after 10/1 will need an IPA to get them in PDPM. That is correct. Oh, and you already answered your question. I'm sorry, I'm scrolling down the questions here. How do you do section GG on usual performance since the patient has already had therapy interventions? That is something that CMS has clarified. The way they worded it at first in section GG was that you should do usual performance before therapy starts, but they actually clarified that to say before the resident has started to realize the benefits of therapy. So assuming that you put somebody on PT and OT, even if you start them on day 1, they're not going to be all better by day 3. So that will still give you enough time to get their usual performance. And also remember, usual performance includes all shifts, all disciplines for that entire 3-day period, not just the therapy gains. So don't worry that they're already on therapy starting day 1. That's okay. You can still get section GG usual performance. So if an ARD is missed and you have to bill some default days, how do you correct it? Can you do another IPA for the transition period? You would only do another IPA if it's appropriate to change the reimbursement. So what you would have to do is, let's say again, you don't set that ARD of the transitional IPA until the 10th. So you're going to have 3 default days for the 8th, 9th, and 10th, or yeah, 7th, 8th. Sorry, 7th, 8th, 9th, 10th, 8th and 9th. So yeah, 3 default days. So you're gonna have to bill those 3 default days just like you would now for an ARD out of compliance. Those 3 default days will come at the beginning of the claim, and then the remainder of that claim will be picked up by whatever PDPM classification would come off of that assessment. So it will pick up with whatever, I want to say rug, but it's not a rug. That PDPM case mix classification comes off of that MDS that will pick up the remaining billing days going forward. If it turns out the residents had a change that would impact the PDPM classification, then you can do an IPA that would set the payment effective with the ARD of that IPA. But don't do an IPA just because you had some default days, because that's not going to fix the default days. Let's see. This is interesting. Would you recommend opening a discharge PPS MDS for all current Medicare people with an ARD of 930, just in case someone goes out before 11:59 p.m.? I think if you really, really want to be sure, you could do that, because technically speaking, you can open an MDS and never complete it, but just in case you would be in compliance. I actually had not even thought about that, but technically, if you really want to have your bases covered, you could do that, and that would be absolutely certain that you'd be in compliance. Okay, so how would you interpret the interrupted stay policy when a patient is in the SNF primarily for therapy, even though they generate a case mix group from other areas, and they miss therapy for 3 days but remain in-house? Would this be similar to monitoring for EOTs? No, it would not be, because it's not an interruption in the stay. An interrupted stay is an actual discontinuation of skilled level of care. So you mentioned in this scenario that the resident is still generating case mix groups for other areas, perhaps nursing and non-therapy ancillaries, for example. It doesn't matter whether or not they're getting therapy in PT and OT for 3 days, because they still meet the skilled level of care requirements for nursing. So don't worry about the skip missing therapy, because the EOT concept is going away. So of course, you would want to continue to monitor to see if there's an actual change in the resident's clinical condition that would require an IPA, but that's not an interrupted stay because the resident is not completely dropped from Medicare coverage, because they're still getting skilled care for other areas, not just therapy, and they're not being physically discharged from the facility. So again, we're decoupling from therapy delivery. Great questions. How do you calculate the day of the discharge for an emergency discharge? Example, discharge order before midnight, the ambulance picks up after midnight. That one's easy. The day of discharge is the day that the resident physically goes out the door. So if the order to send the person out was at 11:45 p.m., but the ambulance doesn't get there until 12:30 a.m., they are being discharged physically from the facility in the following day because midnight has already passed. So just make sure you know what time it is and make sure that gets noted.
And Jen, I would also
Yeah.
add to that, make sure that your census transaction that you enter into your EHR also aligns with that.
Oh, yes, very important. So always write down the time is the takeaway from that. You will, can we do modifications for submitted MDSs? Yes, you can. And I have not seen anything to say that you cannot go back and modify a RUG MDS that you submitted in September if it turns out you needed to do a modification. I haven't seen anything against that as long as the MDS was completed in compliance. So that's okay. Let's see. Is it necessary to use the SNF primary diagnosis in the UB04? It would be best practice to do so. How you prioritize diagnoses on the UB is gonna need another look because, of course, you're prioritizing the PT and the OT diagnoses to support the therapy RUGs, right? But in this case, you're going to have your clinical categorization based on the primary diagnosis. So I would recommend making sure that that primary diagnosis is a valid one. It's not returned to provider, so you can put it on the UB just for the sake, again, of, to Janine's point, your compliance and consistency within your transactional system and your clinical system.
And I would think that if you have a different principal diagnosis on the UB04 than you have on the MDS as the primary medical condition, you are inviting an audit from the Medicare administrative contractor.
It's low-hanging fruit for the auditors. Yeah. They go for the easy stuff first. All right. These are awesome questions. So we're getting towards the end. So after October 1st, on admission, we do the following: the MDS entry tracking form, the initial Medicare assessment / 5-day, and the admission, all separate, or can we combine the admission with the 5-day? After you get past the transition, you will be able to combine. It's just like a 5-day, except CMS is not calling it a 5-day anymore. So you can still combine the 5-day and the admission. The ARD parameters are still the same. It has to be by day 8. So once you're finished with that transitional IPA, you can combine MDSs. It's just that IPAs can never, interim payment assessments can never be combined with any other type of MDS. So once you get past that hump of the transition, then that at least is going to be business as usual. So if the resident, this is my last question, if the resident is out for greater than 3 days, so if they're physically discharged from the facility and then readmits to your facility, do you have to do another 5-day? Yes, because that will be beyond the interrupted stay window. So that requires, that's going to be a whole new stay now. You're going to have to submit that discharge, end of Medicare, saying that the resident's gone out and they're physically discharged, and then you'll need that new 5-day initial Medicare assessment to start a new stay, start a new Medicare stay. Oh no, another question. All right, this really is the last one. What if the resident transferred to the ED at 11:45 p.m. on 9:30 and comes back on 10:01? Do we need to do an IPA? No, because presumably they are going to be out of the facility less than 24 hours. So the midnight rule applies. It's going to be a skip day for billing, but you're not going to need to do you're not going to need to do a discharge for that resident, but it's still the same Medicare stay. So you are going to have to do a transitional IPA in that case because the resident was still on the same Medicare stay, even though they have one skip day. That doesn't impact that piece. So you are going to have to do a transitional IPA for them. You might want to wait a couple of days just to make sure that nothing from that ED visit might need to be documented so that you can capture comorbidities on that assessment. Whew. Okay, I think we are done. So thanks for everybody who stuck around for overtime, and I hope this series has been useful to you. We're here to help you as much as we can, and best of luck, and thank you for attending. And thank you, Janine. Take care, everyone.
Thank you. Bye.